Our first presentation is with Dr. Ruth Braden. Dr. Ruth Braden is from Melbourne, Australia, so she physically couldn't come here, so her presentation will be on a Zoom presentation. She is an early career academic at the University of Melbourne, and she's been a postdoctoral research fellowship on speech and language group with the Murdoch Children's Research Center. If you have never looked into the Murdoch Children's Research Institute, it's a good place to find some information about language development. Since language is one of our key markers with our children, it's definitely the work that she's done is a good indicator. She did her research for her doctorate on our FOXP1. She has a very good article out there on the internet on speech. Severe speech impairment is a distinguishing feature of FOXP1 related disorder. It's on our website if you want to read it, but it's an excellent article to understand how your children both receive and communicate information. So I'm really pleased and honored that Ruth is presenting to us, both in her presentation this morning, and again, she's going to do a breakout group after lunch on communication where there'll be more time for you to ask questions with her. So with that, there she is. Ruth, welcome, and I really am pleased that you're with us today. And I'll just as a footnote to the crowd here, it's midnight in Australia when she's talking to us now, and when she's doing our breakout group, it's 3 a.m. So we'll appreciate that she's in a different time zone than we are right now. But thank you, Ruth, for joining us. And with that, I'm going to say, hand it over to you. I'm going to walk off the stage. Thank you, ladies and gentlemen.
Thank you, Gail. And thank you, everyone, for having me today. It's really exciting to be able to join you all, despite being a very long way away. So I'm just going to share my screen for a second, so bear with me for one tick. Okay, so hopefully you can see my slides there now. Okay, so I'm going to get started with a presentation today, and as Gail has really kindly introduced, I'm going to be speaking about what we know about speech and language abilities in children and adults who have changes in the FOXP1 gene. And to start with a little bit about me, for those who I perhaps haven't met before, although I'm conscious that I've met quite a few of you perhaps. I'm sorry not to be joining you, yes, I have met quite a few of you in the past, and you may already know that I'm a speech pathologist or a speech language pathologist or a speech language therapist, an SLT, depending on whereabouts you are in the world. And I'm zooming in from Melbourne, Australia, so nearly 17,000 kilometres away, or a 24-hour flight. And I'm really sorry that I couldn't join you in person. I'd really hoped to be there, but as we all know, sometimes life gets in the way and these things aren't quite possible. Now, before I start, I'm going to acknowledge the traditional landowners of the place I call home, and from where I'm presenting from today, the Wurundjeri people of the Kulin Nation, and I'm going to pay my respects to their elders, past and present. All right, so a little bit about me. As well as being a speech pathologist, I work in research, and I'm predominantly based now at the University of Melbourne, which is one of the largest universities in the Southern Hemisphere. I also collaborate and did my PhD at the Murdoch Children's Research Institute, which within the speech and language team. And the MCRI, as we call it, sits on site with the Royal Children's Hospital, which is a large paediatric hospital in Melbourne. So lots of my work is in collaboration with Professor Angela Morgan at MCRI, and so I'd just like to thank her at the start of this presentation for her collaboration and contribution to this study. All right, so I'm going to briefly talk through the plan for my talk today. I'm going to start off with some terminology. When we talk about communication, we do have some specific terms we use to describe different features. So I'll get started talking through those just to make sure we're on the same page as we go through. I'm then going to talk about what we know about communication in FOXP1 related disorder and what our study has shown us about the speech and language profile in particular. I'm going to touch on some current projects you can get involved in if you'd like to take part, And then we'll finish with some questions at the end. We'll open that to the floor if anyone has anything they'd like to ask. So put your thinking hats on. Okay, so starting with terminology. Again, I'm sure many of you are already familiar with some of these terms. As a speech pathologist, we'd typically refer to speech impairments, so the production and the perception of sounds, and language impairments, so understanding and using words to express our thoughts and ideas. Now, speech and language are different parts of communication. They use different parts of our brain and they rely on different cognitive processes. So it's important that we distinguish between these when we're thinking about communication. Yes, they're absolutely related and that's really important to acknowledge as well, but we need to be able to differentiate these as well. In particular, we need to differentiate them when we're thinking about therapy. All right, so I'll talk to each of these individually now. So within the umbrella of speech disorders, we have articulation and phonological impairments. Articulation errors are common ones you might hear of, things like a lisp or difficulty saying a sound. Maybe you might say a f instead. Phonological errors can be things like adding, swapping around or removing sounds in words. And this is due to a breakdown in understanding the sound rules in your own language. Children who have phonological errors tend to be doing these in fairly consistent patterns most of the time, and these are always picked up in a speech assessment. Now, articulation and phonological errors are fairly common in the general population, so we see them in about 3 to 4.5% of preschool children, judging by some of our Australian studies, and they tend to resolve naturally or with some intervention. Now, by comparison, you can see in blue here, we have another type of speech disorder which we group together and refer to as motor speech disorders. So you can see here dysarthria, childhood apraxia of speech, and stuttering. Dysarthria refers to some impairment with neuromuscular execution. So there's some weakness or some incoordination of the muscles that we use for speech. Childhood apraxia of speech, also known as CAS or developmental verbal dyspraxia, speech apraxia, there's lots of terms you might see for this one, is another one, and it is a breakdown in the programming and planning stage of speech. What we might see in these children or adults is they might make inconsistent errors. So if you ask them to say a word repeatedly, they might say it different every time. So if we ask them to say hospital, they'd say hospital, hospital, hospital. They might also have errors in linking sounds together in words, and their prosody, so the flow or the rhythm, the intonation patterns using their speech might be a little bit unusual. Now, both dysarthria and apraxia of speech largely result in quite poor intelligibility or difficulty being understood by others, and they tend to be far less tractable to therapy, so they often persist into adulthood. Stuttering is another one I've got down the bottom here. I'm not really going to talk to that today because it's not common or it's not really seen in children with FOXP1 disorder that we've found so far. So we'll leave that one there. Then crossing over to language, we've got receptive, so our comprehension abilities, as well as our reading skills, and expressive, so our spoken language and our written language. So thinking about what we know from the literature, there have been numerous papers which have explored the FOXP1 phenotype, and we know about these core features of autism, intellectual disability, and behavioural difficulties that are so often seen in this group. We also know from many past studies that speech and language is an area of difficulty for children with FOXP1. Now, our challenge before we started our study was that most studies have stated terms or used terms like speech disorder, speech impairment, communication impairment, absent speech. And so while we get the general idea that there's this difficulty with communication, we really don't have that specific information about which domains that difficulty is occurring in. So is it speech or language? And if it's speech, which particular area of speech? From past studies, there was a bit more data on language available. And we know that some of these studies have done some testing of receptive and expressive language abilities, which was great. But we also need to see how these abilities compare to speech profiles. We want to see the whole picture of communication. The reason this is important is because we need this information for therapy. So parents want to know what their child's speech will sound like, what the prognosis is, and how they can best support it in therapy. So we need the right data to understand this, and as research and clinicians to go on and develop more targeted therapy approaches. Okay, so we conducted a study, and I'll go through this now. You can see here we included patients right from babies, so 9-month-olds up to adults, and we really wanted to see the whole picture across the lifespan. In order to participate, individuals had to have a pathogenic FOXP1 variant, and that had to be confirmed on a genetic test. We recruited our participants from databases in Australia. We've got some really wonderful databases here at the Murdoch Children's Research Institute, but we also spoke to online parent support groups, and the FOXP1 Foundation was really helpful with recruitment here. So I thank everyone for their assistance there. And we saw participants from right across the world. Now, data for our study was primarily collected over telehealth. We did have some Australian-based participants too, who we saw in person, which was really wonderful. So here's the assessments we did. So we conducted a health and medical survey, and this was quite a comprehensive survey, which has allowed us to build a really rich database on a range of areas. So looking at development, health and medical diagnoses across the lifespan. We also compared that data to past reports or medical records. We looked at speech production, perhaps unsurprisingly, and we were able to differentially look at each of those conditions that I spoke about on that earlier slide. Language assessments were completed. We used an assessment called the Vineland Adaptive Behaviour Scales. We were able to use the language indexes from that test. And we also collected data on non-verbal IQ from reports and did some assessments with our Australian kids. Oral motor assessment is also something we completed. So we were looking at the structure and the functions and the movements of the mouth, lips and face to try and give us a good picture of the overall movement and coordination of those muscles. Okay, so thinking about results, we had 29 participants take part. 17 were female and 12 males, and you can see our age range was from 2-year-olds up until 33-year-olds. Now, we had lots of languages involved, which was really great to see. As Gail mentioned before, there's lovely networks right across the globe for FOXP1 disorder, so it was great to have some representation from many different countries. Mostly the data we found in terms of health and medical features supported what we knew from other studies. So features of intellectual disability, autism, attention difficulties, they come up in 52% of cases, and some of those children had ADHD diagnoses, whereas others didn't have a formal diagnosis. Parents were just reporting some concerns or some attentional difficulties there. So if we think about communication milestones, what we found out is probably supported by previous work again, and that's that first words were typically coming a bit later than typically develop in peers, and that this had a flow-on effect for when children started putting words together to form sentences. What we found, though, is that most children and adults were using sentences by the time they got to school, so around 5 years of age. So you can see in this circle here the first words, so the ages children had their first words. Now, within our sample, we had a range of children who used verbal speech as their primary mode of communication. And you can see that's the 21 participants here in the larger purple circle, getting my words mixed up. And we also had 8 children, you can see there, who we would refer to as minimally verbal, or were using other modes of communication other than verbal communication. I should say that 5 of those 8 were young and still working on their communication. So I'm not necessarily saying that all 8 of those individuals will continue to be minimally verbal. We suspect that some of those will become verbal communicators or have already. This data was collected a couple of years ago, but 3 of them were older participants, so they were aged older than 7 years, and they weren't yet using verbal speech. They were communicating using signs, so keyword signs or more comprehensive signs, and some communication devices like a picture exchange system, for example. Now, in the 21 who were using verbal speech, we do know that they were experiencing difficulty being understood. So they had persistent difficulties with intelligibility, how well other people are understanding them. And this was particularly notable for people outside of their family, so people who were less familiar with their speech and their speech patterns. I thought I'd break down the speech production a bit more here, because this is the bit that's really important when we're thinking about what to access and target in speech therapy. Now, this is similar to the slide I showed you earlier, so it might look familiar. But you can see here in orange. So all of our verbal participants who provided a speech sample for analysis had dysarthria. So that was the impairment in the coordination and strength of the muscles we use for speech. Now, generally, this affects speech across all the sounds and words the child is making. And in particular, with this group, back to dysarthria. So we know that generally this is affecting speech across all the sounds in words, so it's reasonably consistent. And in particular, in this group, we saw features like resonance, so sounding a bit nasal or having a little bit too much or too little air coming out of your nose was a really dominant feature. We also saw some generalised imprecision across sounds and words, and some difficulty with prosody, so difficulties with intonation, that flow and rhythm of speech. There was also some mild pitch, loudness and voice deficits, which we can talk about maybe a bit more in the breakout room later if anyone is interested. You can also see here that 100% of our kids, so all of our verbal children who participated, had speech apraxia or features of speech apraxia. So they made those inconsistent errors, saying that same word differently on different repetitions. They also struggled to link sounds together smoothly, and they had more difficulty with pronunciation as words became longer and more complex. So words like spaghetti or octopus or ambulance were less precise than words that were a bit shorter. Emitting sounds was another common feature, and all these things are frequently seen in apraxia of speech. If we move across to our more common speech disorders, we saw that phonological delay and disorder, phonological error patterns were also common in 88%. So examples of this might be things like cluster reduction, so dropping sounds which go together in a cluster. So block might become bock, or spider might become bider, or you might have weak syllable deletion, so saying marto instead of tomato. That's an Australian example, actually. It's probably not so relevant for everyone in the US and Canada, I appreciate. Now, some of our participants also had disordered phonological error patterns. So these are things we don't see as commonly in typical development of speech. This might be things like vowel errors, so saying big instead of bug. And then again, we have some articulation errors coming through. So lists, difficulty pronouncing certain sounds like and. I'll move on to language. So overall, our language abilities, again, supported previous studies that showed that this was an area of difficulty. But we did also have quite a range of language abilities within our cohort, which we thought was really interesting. Now, because of the sample size that we had, it wasn't a huge study, but it was enough. We were able to do some further analysis of the types of gene changes that each participant has. And we could group these into two groups. So one where we predicted that the gene change might result in some more challenges, and another one where we hypothesised that gene change might have a slightly milder effect. And what we found was this proved true for language. So the group who had the more severe type of variant, or the variant we thought might impact language more significantly, tended to perform slightly lower on those language tasks as a whole. And this was compared to the other group who performed relatively better. Within that larger group who had a bit more trouble with language, we found that their expressive skills, though, were a relative strength over their receptive abilities, which was really interesting. And I think that's an important thing to consider for therapy as well. So in summary from our study, we know this is quite a complex phenotype, particularly regarding the speech, dysarthria, apraxia, phonological errors, articulation errors. So there's lots of things feeding into this speech and contributing to that intelligibility that I mentioned earlier. That's why it's so difficult for some children to be understood even into adulthood. We also know that language is an area of difficulty and that this may be influenced by the type of gene change, but it would be interesting to have larger studies and more studies so we could interrogate that a little bit further. So, why is this important? It's information for families and speech pathologists. We know that most people with FOXP1 related disorder are going to develop verbal language despite having some early delays. And I think that's a really important thing for families to know, particularly if they're receiving a diagnosis and their child is quite young. We know that the speech disorder is complex and that intelligibility is remaining a challenge right into adulthood in a lot of participants. But we also know that with some maturity, so with some age and with some access to targeted and intensive speech therapies, this is something that will likely improve. It's also something we can treat. And children need to be referred to speech therapy early when they're diagnosed. In particular, we'd like children to be referred for dysarthria therapy. Something that came out of our paper was that despite having such a high incidence of dysarthria, none of the children were doing targeted dysarthria therapy with their speech language pathologists. So I think that's really something to harness and have a think about going forward. Now, my study, as Heather mentioned before, was published in Developmental Medicine and Child Neurology in 2021. It was actually published 3 days after my daughter was born, so we had everything happening at once. But it's great to have that out there, and if anyone would like to access this and is having trouble, do just send me an email and I'm happy to send you a copy. All right, so going forward, what does this mean for research? I'm a researcher, so what does this mean for us and our team? We'd really like to know next how speech changes over time. If we understand we know how speech is is, or what's happening with speech at a single time point. That's what we've already looked at in our study. But now we need to know how this speech changes over time. Do the speech features change? Do we have a lot of progress happening in short bursts? We need to have a good look at this and work out what ages and stages we can expect that change to occur. One of the reasons for doing this is because we'd really like to develop some targeted therapy approaches. And these might be behavioural therapy approaches, but there's also increasing evidence for using or introducing some drug trials looking at speech and language disorders. But we can't think about those things if we're not sure or we don't have a really good grasp of this speech and language phenotype and how that changes over time. Having that information will also give us some more information for families and speech pathologists about prognosis as well. So if you'd like to get involved, the study that I'm currently working on and currently plugging to all today is our speech tracker study. So this is tracking changes in speech over a 3-year period. So if you sign up for the study, you'll have a time point check-in every 6 months over 3 years. And in that check-in, there'll be some online parent-completed surveys. So if you've worked with us in the past, we can use the data that you've already given us and just send you some questions for updating to see what's changed since I last spoke to you. Or otherwise, we can start from the start. Either way is fine. And on top of this, we send an online speech task for your child to complete. So you just complete it on your mobile device or a laptop, anything you're using. It'll ask your child to make some funny sounds, to say for as long as they can, and they'll also have some pictures to name. And that's all data that gets sent back to me, and we'll analyse it and look at the speech features from there. So if you'd like to get involved, you can scan the QR code here. That should be working okay. And this poster was also in the poster presentation session, so you can have a look there if the QR code is too large on the screen or too far away today. I've also put my email address there, ruth.braden@mcri.edu.au, if you have any questions or you'd like to find out more about the study. So a big thank you before we go to questions to my co-authors and collaborators. So Professor Angela Morgan and Professor Ingrid Scheffer in particular, who were my PhD supervisors. I did this study as a large component of my PhD, so I'm very grateful to them for their time and supervision. I'd also really like to thank the International FOXP1 Foundation for having me today. It's a pleasure to speak, even from so far away. And thank you to Gail, especially for organising me from the other side of the world. But most of all, I'd really like to thank the families who have participated in our studies. It's been such a pleasure to work with you all and to learn from you all and get to know your families and your little fox, or not so little in many cases, your fox children. And I look forward to meeting more of you in person, I hope, in the future. So with that in mind, are there any questions?
Hi, Dr. Braden. Thank you for the talk. That was really great. One of the things that I was thinking about during your talk was, how with the, you showed the kind of pie chart of the different families and how the kids presented. Have you been able to kind of triage that against the types of genetic mutations? So like one of the things that we've seen from the kids is definitely a spectrum of challenges from the different kids, and from the genetic analysis, there's some different types of mutations. There's kids that don't have a FOXP1 protein at all. There's kids that have a FOXP1 protein that is maybe defective in some way, or is that something you've looked at, or is that something you can go back and triage against?
Yeah, that's a really good question, and I apologise. I can actually only see the back of all of you, so I can't see your faces. Thank you. Yes, very good question, and I think there's probably a bit to consider there. So, in my study broadly, I probably grouped participants more according to the type of variant they had. So whether they had a truncating variant, for example, or a missense variant, which we might expect to be a little bit more mild, or then again, if we had participants who had a larger deletion. So, for example, there was one participant that had a larger deletion, so that included FOXP1 as well as some other genes on the other side of that. And so that phenotype tended to be a little bit more severe. The language findings showed that we knew the children who had the missense variants were slightly milder presentation compared to children who had the truncating variants and the in-frame deletions. But on an individual level, I haven't done a really thorough analysis of comparing the type of gene protein product change with the speech and language findings. There is one participant we did do that on, and that was they had a paternally inherited variant. So rather than a spontaneous variant, which is what occurs most of the time, as we all know, sometimes this can be inherited. So we did do some further analysis on that participant, but I think it would be really interesting to do that. And as we get larger cohorts together where we've got multiple children who might have the same or a very similar change in that gene, I think that data will be stronger and something we can definitely look at. Yeah.
Oh, that's great. Well, we're on the the leadership team. We've been working with RareX, who's really doing a good job of kind of consolidating information. So, I would invite you to make sure try to work with them and also let us know how it is working with them and if it's how it benefits your study.
Yeah, thank you. And RareX is a group that our broader group have worked with before. So yes, I'm on it. We'll see what we can do.
Hi there. So if we have a child working already with a speech pathologist doing speech therapy, but they don't know the child has FOXP1, is this something helpful to tell them because there's so little known about it? It seems from your presentation that maybe they should target these certain areas that perhaps are not being targeted. Should we give them your study, or what do you suggest we do to now suddenly inform a speech therapist who didn't know that the child had the FOXP1?
Yeah, that's a really good question. So I've got a little bit about this in the breakout session later, so I apologise if I'm repeating myself a little bit to anyone who joins us in the next session. But yes, I would say absolutely. I think it is helpful and important for the speech pathologist to know about the genetic diagnosis. Of course, only if you as the family feel comfortable sharing that with them. The reason that I think it's important to know is because of this complex speech profile that I've mentioned. Often we often don't have children come through who have such complex profiles. And I know where our research started was from seeing some children who had FOXP1 disorder and the clinicians just saying, I just don't know where to start. I'm not really sure what's going on. I'm not really sure how this is going to change over time. I know they've got some features of apraxia. I know their resonance is off, so I think they've got some dysarthria. They've got some artic and phonological errors, and what's going on here? So I think for a speech therapist to know that we would expect perhaps for the communication or the speech phenotype in particular to be fairly complex, that would be helpful, mainly just so they can plan to do a really comprehensive assessment. And try and pull this apart. Not every child, as you all know, is going to be the same, but I think that information would be helpful. Sharing my paper is a good place to start. It is the only one that's really systematically looked at speech and language in FOXP1 to date. And there's also some information available on our website, the Genetics of Speech Disorders, if that's helpful to direct clinicians to as well.
Hi, Dr. Braden. Thank you so much for your talk. I think it's great that you're going to be doing longitudinal analyses. I don't know where to look. Should I look that way? So my son, Jonah, is 18, and he is very difficult to understand, but I think he's also more difficult to understand now than he was 10 years ago. So I'm wondering if you have any information yet about, I guess, loss in articulation skills or increase in apraxia over time.
Well, that's a tough one. The short answer is no, because we haven't got this longitudinal data. I'm not sure. I don't recall finding in our study that a lot of families were reporting some regression in that speech intelligibility. But that said, I would say that a lot of our participants sort of were more of that younger age group. So we don't have a huge amount of adult participants or older teenagers that I can speak to there. I think it'd be really interesting to find out more and to get some thorough case history information as well around that speech and language development and change over time. We know sometimes that speech and language can be influenced by other medical components which are associated with the FOXP1 condition. But without knowing the exact case, it's hard to speak to. But yeah, something I'd like to look at and something that would be important for us to know if that is what's happening.
Okay, thank you. So more research, more data points, more participation, right?
I think so, yeah.
Thank you. Great job. That was going to be my question, so now I had to come up with another one since I was already up there. So when you think about some of the effects with the mispronunciations and things like that, is that, you think, more neural or muscular? And that they have the tone problems. A lot of the foxes have the muscle tone problems in the mouth. And I know with my son, getting him to put his tongue to his teeth to say an L is very difficult. So is it neuromuscular or is it more neural? And then when you tie that in with, because he was delayed, we started with sign language, which he picked up very easily. So the neural understanding is there, yeah. Thank you, please, drink. Yeah, he picked them all up, but can't say it.
Yeah. So I would say there's a few different levels we need to think about when we're considering where this breakdown in the intelligibility is occurring. So apraxia of speech, the condition I mentioned, that's sort of a really high up level breakdown in programming and planning. So the child knows what they want to say, but they have to retrieve that motor plan. So how they're going to, what the message is that they need to send down to their mouth, really, and their lungs to coordinate to make all the right movements for speech. So that's the apraxia side of things. That's that really high level control. Stepping down from that a little bit, though, is the dysarthria. So that is where these tone, if there's some disruptions to the tone, particularly if there's low tone or high tone, we will see that come through in the dysarthric features, but also that coordination level. So to answer your question, I'd say it's a bit of both. And that's adding to this complexity here. And that's why we need to have this differential diagnosis to be able to work out which features to treat, what we think is having the largest impact on the intelligibility or on the speech, and trying to work on that first. And that might vary a little bit between individuals. Some might have far more profound dysarthria features and others might have more profound apraxia. I would say on a whole, though, that I think the general profile is mostly the dysarthric profile. So so the execution or the control and coordination and strength of the muscles.
Hello, my daughter is 8. Her name's Elise, and I was just wondering if, I don't know if there was enough of a population or enough language sample from the kids that you saw, if you were seeing if anyone was a Gestalt learner, because we've learned that that's a way that she's really picked up a lot of speech, and I kind of feel like, I don't know if that's a wild card, or if that's something that you've noticed with some kids as after they can talk that they're learning that way.
Yeah, I think that's a really interesting question. So, on my other hat that I wear is that I'm the language lecturer at Melbourne University for our Master of Speech Pathology students. So, Gestalt language process is definitely something I'm across. Although I'd say it's not something that I gathered data on my study. The Gestalt language processing is an interesting space, and it's a really fast developing space in speech language pathology at the moment. It's been around for a long time. Certainly the ideas of it are not super new ones, but it's really gained a lot of momentum, particularly in the last couple of years. So even at the time that I collected this data, the Gestalt language processing wasn't something that was really coming up a lot or something that clinicians were entering into. There's emerging evidence for it as a therapy technique, but I don't really have the data on whether I think that Gestalt language processes or not. So I'm not sure I can give you a good answer to your question, but I'm curious to find out more.
Thank you very much. I appreciate it.
Hello, Dr. Braden. My name is Manuel. I'm the ambassador from Switzerland. Our son is 4, and he's just starting to make some noise and some intonations. And we are in a position where we're getting different mixed signals. He's very enthusiastic about making noise, as I would call it. The ABA therapists are trying to hold us back, saying, well, go slowly about it, don't pressure, be very, very slow around it. And I was wondering, in your experience, is there a particular approach or a center of competence or a certain, methodology that can be employed where you've seen that this really works well in those children?
Yes, but it really, I think the first place to start would really be having a comprehensive assessment to try and work out what the difficulty is. So thinking about the underlying language abilities. So that communicative intent, is how many gestures or signs, for example, might be there. There might be lots of signs or gestures, or maybe that's not something that's happening so much. And then looking at the speech sounds separately, so thinking about the phonetic inventory or what sounds is your son able to make versus sounds he might not be making at the moment. So it's a bit hard to work out what target approach would be best without having all that information. Certainly as children are starting to speak, language stimulation approaches, so things that are really encouraging them to start using some first words and then starting to put some words together, are important, and equally just trying to get some communication. So using some gestures and signs is really important, and perhaps something you're already doing. It's a bit hard to say without having assessment. Everyone's a little bit different, and particularly at that young age, we know there can be quite a lot of variation.
Right. Thank you very much.
Hello, Dr. Braden. Thank you for your presentation and for the article, which I'll happily share with my daughter's speech therapist. Over the years, she's expressed frustration, to say the least, that her lisp has not improved, and I've tried to share that, well, it's a little bit more complex than just a lisp. So the article, I think, will help. Now, my question is more around whether or not it's ever been looked at the shape of mouth of FOXP1 kids and the shape of their palate. My daughter Isla, for one, has a very, very narrow, elevated upper palate. And of course, that makes the muscle strength required to bring her tongue up to the top of her mouth much more difficult. And I just wasn't sure if this was being ever looked at, that the shape of our kids' mouths sort of add to the complexity of their speech difficulties. So thank you.
Yeah, really good question and an important area to consider. So in our study, for our Australian participants who I met in person, part of their oral motor exam was a structural assessment. So I had a look in their mouth with a little torch and had a good look at palates, wanting to see if there was any signs of having a cleft palate or a submucous palate, so whether the palate was joined into the nasal cavity above or whether we had that structural hard palate and then soft palate at the back in place, which is what we would expect. And in the children that I saw, there weren't any signs of cleft palate or submucous cleft palate, but I didn't have a huge amount of Australian participants. Most of our numbers came from overseas, and as you can appreciate, it's a little bit hard to do a good look on a telehealth assessment. So I think that would be something that would be helpful to look at. In other conditions I've studied, I've also seen those high palates, or I might call it a high arched palate. So there's some vaulting or a section in the middle that's quite a lot higher up. And as you say, and can imagine, having that tongue contact with the palate, so having those really precise articulation is probably going to be a little bit challenging with that in place. So is it a feature that I'm sure is associated with FOXP1? I can't really say, but I wouldn't be surprised if we did see that in more children.
Hi, thank you for coming and speaking with us. Question about dysarthria and specific type of therapies. I know, for stroke patients, they use specific type of therapies. My daughter's 2, and we just started prompt therapy. Is there any type of therapy you would recommend that we look into for speech for her or anybody?
Yeah, good question. As you mentioned, there's been historically more research on dysarthria in the adult space compared to the pediatric space, especially in terms of high level or high quality evidence for speech therapy approaches. We do have evidence for dysarthria therapy in children though. So one program, for example, is called LSVT Loud, which is based off an adult program. But whether or not these are really at a level for a 2-year-old, I think they might be a bit challenging for now. It's something we're looking to develop though, because we know that there's not there's not a lot of approaches available for dysarthria, particularly in young children, and that's something that we need to improve as a profession. So it's a bit of a watch this space, but there is some literature available, and I'm happy I'll talk to that a bit in the breakout room as well. But yeah, there's some information online, but it's tricky to find them.
Thank you.
I think we're up to
Dr.
our last
Braden.
question.
Hi, I'm Dr. Pagas Bather from Chicago, Illinois. I have a child who is 5 years old and was diagnosed at around age 2. And I'm curious because we have actually 2 other children who appear to be unaffected by FOXP1. And you mentioned hereditary, cases. So I was curious about whether those are thought to be germline mutations, or how do we think those hereditary cases of FOXP1 arose?
Yes, so I've only seen one case of this in our cohort, and in fact, in that case, it was a paternally inherited case, but the dad was not available for participation. So while I know that was a paternally inherited variant, which was confirmed through the genetic analysis, I'm not sure what the phenotype was like in the father, other than that he was had the variant. I think it's very rare for it to be passed along. And certainly the child I saw who had inherited that variant had a milder phenotype. So being passed on in a dominant fashion, but I don't have a huge amount of detail on that. It'd be something more for a clinical geneticist probably to help with that one. I'm sorry, it's probably a little bit out of my remit.
Thank you, though, for that information.
Hi, I wanted to see if I could sneak one more question in before we're out of time. Or are we done?
I don't.
Okay. All right, I'll see you in the breakout.
All right.
Ruth, I want to thank you for your presentation and your questions and answers, and thank everyone for participating and bringing great questions to her. I encourage you to have a little sleep, and we'll see you back here in 3.5 hours in the middle of your night, but in the afternoon for us. So thank you very much, Ruth. Appreciate that.
That was fabulous. Thank you very much for having me.